Don't clap too early. Okay. Better? Okay. Right. So, second topic I'm asked to talk about, and we have very little data in the world on this subject. So, it will be moderately provocative with The Last of Us. I don't want anybody thinking that we're doing ECMO in Outbreak or Andromeda strain. Disclosures here, again, no relevant disclosures for this talk. So, how do we even get here? What is special pathogen? For everyone here in the U.S., the Department of Health and Human Services is overseeing a project through one of its subsidiary branches, the Administration of Strategic Preparedness and Response, which, if everyone recalls, back in 2014 when we had domestic Ebola patients treated in the U.S., there was no infrastructure or programmatic process to take care of these patients. And so at that time, something called NETEC, which was the National Ebola Training and Education Center, was formed in response to this, and subsequently has been more broadly expanded into the National Emerging Special Pathogens Training and Education Center, for which we have regional emerging special pathogen treatment centers. Anything that is federally associated, I think, has to have at least 25 acronyms involved. I forget them routinely. I have them spelled out for myself here. And you can see here, kind of as a timeline, the Ebola outbreak in 2014, subsequently followed by the COVID-19 pandemic, led to the formalization of this process and this national infrastructure, which more broadly we would call the NSPS, or the National Special Pathogen System. So the mission here is to just create this network of high quality special pathogen care centers across the nation. When we look at the map here, we have 10 regions that have been established here, with 13 hospitals participating. And what they've really done here is to copy the hub and spoke approach that other disease processes have utilized. Hubs are the level one regional centers. They do a lot. They are prepared to handle any patient with special pathogen infection or PUI, patient under investigation. Level twos can provide specialized care, but they don't have the full coterie of resources available. Levels 3 and 4, these are sites that are trained and prepared to identify and, for a very short period of time, safely care for these patients while they are up triaged to a level 2 or a level 1 center. So, just talked about Ebola at an ECMO lecture. So let's prevent the slippery slope. Did anybody in here ever have COVID or 2009 H1N1 flu or SARS virus during 2002, 2004? Congratulations, you have been a special pathogen patient. You have firsthand experience. These are, we think of these things as like Ebola, Marburg, the MERS virus, all of these kind of catastrophic infections that are kind of the boogeyman of medicine right now. But realistically, these are highly pathogenic infections that have opportunity for treatment with appropriate care and management. So, like, what constitutes a special pathogen? So I kind of broke this up into three categories here. So we'll look at the viral hemorrhagic fevers. So that's Ebola, Marburg, Lassa, Crimean Congo hemorrhagic fever, Hantavirus is included in this as well. We have highly pathogenic respiratory infections. So we've got SARS-CoV, Middle East respiratory syndrome, highly pathogenic avian influenza, so like the H5N1 that we're always worried about, transitioning from avians to humans with the fear of human-to-human transmission subsequently. And then novel influenza strains with pandemic potential, like we last saw in 2009. We have other high consequence pathogens. It's kind of a mixed bag here. We have most recently monkeypox, pneumonic plague, hendrovirus, et cetera. So again, it feels a little bizarre to talk about these things. And at my home institution at MedStar Washington Hospital Center, two of my colleagues administer our biocontainment unit, which is the RESP TC for our region. And they approached me about offering ECMO in this space, and I said, well, that's just something that we're not going to do. But we talked more and more about it. We talked more about how this is the next step from the COVID pandemic, that we should be prepared to offer it, and we should have a thought process into how we would offer it and what would that look like. So I said, well, let's talk. Give me some time to think about this, and we'll go over it. I personally have a big interest in medical history. I think our last talk gave us a good insight into the past. I think we have a lot to learn from the past. I would encourage anybody who's never done any significant reading on it to go back and read about what the 1918 influenza pandemic looked like. How were things managed from that? These are photos from that period. When you look at this period of time, national public health, all national public health initiatives in the vein that we know them today were a byproduct to global response to Spanish flu. Incorrectly named. Spanish got a raw deal on that. It's from Kansas. Public health agencies became permanent bodies. That was not the case in the past. They had surveillance, prevention, preparation as mandates that followed their creation, and the duty to have a reactive response to emerging diseases. That pandemic led directly to the formation of the CDC and the WHO. And so disease surveillance, formal public health education, all of these things were enacted in a durable, long-standing form as a direct byproduct of a special pathogen. We even had legal measures enacted to support public health. This is where we got the first mask mandates in 1918, first quarantine implementations, school closures, things like that. And what does that look like in the modern world? Well, let's go back to this. We have an entire infrastructure that has been established to identify rapidly and early patients who may be infected with this broad term special pathogens. And we have created this infrastructure to both take care of those patients, but to protect this public at large. And this is the first line for the next global pandemic, because if we listen to experts in the field, it's not a matter of if, it's a matter of when. And so this will be the location where we get the best understanding of how to take care of and how to manage these patients. So we have to have had some experience with ECMO in patients like this, right? We can look at this publication from a group in Saudi Arabia describing their experience. They had a very measured approach when the MERS virus was kind of running rampant through Saudi Arabia, and they set up what many other countries have done, what the Italians did in the 2009 H1N1 pandemic, what Giles Peak did so nicely with Caesar in the UK, what's been done regionally in the US and other locales, and created a nationwide resource to refer patients from non-ECMO centers to ECMO centers. They created nationally agreed upon paradigms for what is inclusion, exclusion, what is an escalation pathway, and really just a great example for how to approach this scenario. So just a refresher for everyone, the MERS virus is a COVID variant, first described in 2012. It causes significant hypoxemic respiratory failure, and we saw the majority of these cases in Saudi Arabia. If everybody remembers the news, it was a little touch and go. We were concerned, I think, about globalization of this virus at the time. One of the things that really helped us out was honestly how pathogenic it is. People got too sick too fast to be able to spread it more broadly. We look at here in Saudi Arabia, just over 1,500 cases confirmed, 41% died. That's a pretty high mortality rate for a respiratory virus. So what was their experience? So this is a small volume study, as you would expect for something in this realm. But this is a retrospective cohort study. For anybody who's statistically minded, this is not the strongest data we would bring forward in the world. But 35 patients included, 17 of them received ECMO, and then they went back and did a cohort matching and found 18 conventional therapy patients that met criteria for escalation to ECMO but did not get cannulated for ECMO. So the ECMO group met those predetermined inclusion criteria. The conventional therapy also met that inclusion group but just did not receive ECMO. And just for clarification, they did not receive ECMO because just the call was not made. They were not declined, so it's not that level of confirmation bias. We look at the outcome here. Again, we have about a 40% survival in the ECMO group and a 100% mortality in patients who did not receive ECMO. Some of the ICU length of stay, hospital length of stay, things like that are a little difficult to match because hospitals were so overfilled. You had ventilated patients on the floor, patients who were thought to not have a good opportunity for survival were not escalated to the ICU, or they were awaiting ICU, things like that. So the mortality data I think is useful, but the length of stay for ICU or hospital is a little iffy and confounding. So anybody from the Southwest? Here. All right. So, Hanta, for those of us who don't live in that part of the country, Hanta virus is not a super common experience for us. I had a close run-in with a patient in Oklahoma once. The public health department was anxious, but not a massively uncommon event there, and certainly not in South America. So is there experience with ECMO in this patient population? Yeah, absolutely. A program in Albuquerque has quite a robust experience with management of hantavirus cardiopulmonary syndrome. So the paper masquerades as a primer for disease management, but the story here I think is their experience. They took 40 patients that had cardiogenic shock, severe hypoxemic respiratory failure with hantavirus, managed those with ECMO, with 25 of the 40 surviving, so 63% survival to discharge with good quality life. And the latter, and their mortality was really heavily weighted in the front third to half of the period of time where they were doing this. They were in the latter half of this experience. It was closer to 73, 75%. I mean, this is pretty impressive. Prevalence of the disease was such that they actually protocolized a management process for this, so that when hantavirus patients came into the hospital and were progressing to the point of shock and severe hypoxia, respiratory failure, refractory to interventions, it was a clear step to move forward to ECMO. But isn't Hanta not transmissible from human to human? Correct. So this is a little less worrisome than, say, I'm asking somebody to come put a patient with Ebola on ECMO. But mostly Hanta isn't transmissible from human to human. What we see in North America is the Sin Nombre variant of the virus. That's never been documented to be transmitted human to human. The Andes virus variant of Hanta has been documented for human to human transmission in both household and hospital settings. I think the important lesson here is that viral hemorrhagic fever patients could be successfully treated with ECMO. I think that's a pretty profound statement. I think that's our proof of concept. But if we looked at this in any other areas, I think we have some obvious ones. H1N1. There are a few kind of novel viruses that we're seeing in Southeastern Asia. The severe fever with thrombocytopenia syndrome, the SFTS virus. Those patients will present with fulminant myocarditis. We're seeing more and more opportunity here to deploy this therapy. So we can do it. Should we do it? It's okay. So let's talk logistics here. As part of my involvement with our biocontainment unit, we have quarterly training that goes into this, and so the level of PPE that you have to put on is kind of sobering when you're like, and how many pairs of gloves do I wear, and how thick is the Tyvek suit? And it's not a little ask, right? So when we talk about just the practicality of day-to-day care, so can we do it? Sure, we can put anybody on ECMO, but how do we manage people on ECMO? Just the day-to-day care for patients who are not ventilated, who are a special pathogen patient that are in a biocontainment unit is orders of magnitude more complex than it would be just in a regular ICU setting. If we want to add ECMO to that, we've again added another order of magnitude of difficulty. So what does the BCU look like? You can look at most of these programs in the US and they will have some sort of schematic of what their unit looks like, but it's a dedicated care space with basically the entire unit is a negative pressure space. There is dedicated separate air handling, negative pressure. You have dedicated lab equipment. We don't even take blood samples for PUIs in that unit out of that unit. So it's a dedicated lab in that space. Every blood sample is an opportunity for pathogen transmission. We have dedicated radiology equipment. We don't want to shoot a chest X-ray on this patient and then go give grandma with pneumonia Ebola. So we have a dedicated autoclave, separate sterilization procedures. Staff training is ongoing. There are drills for appropriate donning and doffing of PPE. We have specialized waste disposal, on and on and on. This is not our BCU, but I love this graphic more than what we have. And so I think there's a lot of color coding here. And as you might expect, green is good, yellow is caution, red is the hot zone. So this is kind of a single room diagram. But when we look here in the top left where we see the number 2, that red area, so that's your patient room. Your green box there to the left is where you would don your PPE, enter the kind of the hot space. The yellow zone is where you would doff your PPE, sanitize, and then exit back into the green. The red there at the bottom is the lab. So any place where a patient is, or where blood, sputum, any bodily fluids will be, those are red areas. Those are hot areas. It is essential that we kind of contain that, and you have the appropriate process for PPE. When we doff PPE, when we come out of these spaces, you're under direct observation. You have a checklist that is gone through with you. Someone is observing to make sure that you don't contaminate yourself. So this is the level of rigor that's required to go through this process. How many times do we go into a patient's room a day when we're taking care of ECMO patients? 10, 15, 20, who knows? So what does this look like from a practical standpoint? For anybody who hasn't actually seen this PPE, some of these images are from our center. Some of these are from other BCUs. At our program, critical care is the primary service line. All of these patients are admitted under our service, but we have team members with ID, OBGYN, neonatology, peds, surgery, the bioethics team. Telehealth is involved, and then MedStar Transport is our in-house medical transport service for ground and air transport. We drill to do crash C-sections in this space, to have vaginal deliveries performed. Acute care general surgery is part of the team, so that if these patients have a surgical need, that can be done in that space as well. Labs, man, we love labs, don't we? Like we are a lab-heavy group of people at this meeting. We have to minimize how often we even access the patient for blood. We're also limited on the scope of the testing that's available. We can't put a full complement lab in this space. So we're not checking antithrombin 3 activity. We're not getting plasma-free hemoglobins here. There's no TEG, ROTAM. You're getting chemistries and CBCs, cultures, and PCRs, and maybe some point-of-care testing, but that's it. It's non-invasive monitoring as you're able. And I think this would force a change in practice for a lot of people. And I think, if we look at how do we learn lessons from this space, and how do we take the austerity in that space and apply it out, like how did everybody enjoy the IV fluid shortage? Was that challenging? Cardiac surgery, I think, got a little bit of a pass in that, but not a full one. But raise your hand if your hospital or your group is maintaining a lot of the measures that you implemented during the IV fluid shortage. Ours certainly is. I think the hospital realized, we could save money and not sacrifice outcomes. Great. I think there's lessons like that to learn out of this space as well. This, I think, is always the question. It's like, this sounds great. Who's going to do that? Because it's not me. I think the logistics of bedside care in this space is very different from what we're used to as a routine. It's just difficult to manage overall. A core directive here is that you want to minimize the number of times someone goes into and out of that space. That is the riskiest part of the patient care. And so, do we need a nurse and an ECMO specialist, or a nurse and a perfusionist? Do we need maybe a perfusionist or a specialist that's going to give direction through a window or over a microphone? This is all something that would have to be worked out by your team at the site. There is no standardization even across the 13 BCUs in the nation. That's something that we're working on right now, is to come up with with a standardized approach to how we would both select patients for ECMO and then how we would manage them once they go on. So, takeaways here: pandemic level special pathogen infections are likely to occur again. We have the infrastructure to mobilize and care for these patients. We've done ECMO in kind of concerning pathogen patients globally, maybe not on the grandest scale outside of COVID, but I think COVID showed us that it was possible, that we could be successful with it, and that in the early phase we had a lot of lessons to learn. Extensive planning has to be put in place to ensure that we deploy it safely, appropriately, and judiciously, because it is a critical resource, and we have to be careful about how we put it out there into the world. And that's it.
Thank you, Michael, for your nice talk. So any questions from the audience?
Yes. Very interesting, kind of scary as well, what can be unleashed. I'm just curious your thoughts on what we've been seeing, with germ warfare, the international labs that are creating and working on viruses that transfer from animals to humans, and the Wuhan thing that we all experienced with the COVID. And now they talk about a bird flu that's supposed to be our next pandemic. I'm just curious your thoughts in relation to the potentials, that could be coming at us in that respect.
So I'll give the caveat that I don't think I'm an expert or I'm certainly not an ID special pathogen expert. I think I'm a yeoman on the team. I think our leaders stay pretty keyed into what are the concerning things on the forefront, and I think the novel coronaviruses, influenza, I think common things being common are the more likely next batters up, as it were, just for the ease of transmission and accommodation of the host. But in terms of like what in particular, I don't have a good answer.
Dr. Harper, thank you for a good talk. I know that you talked about dedicated equipment in these rooms, and in the circumstance where that may not be feasible or may not be possible, or that level of rigor has not been developed yet, what is your experience? You may not be an expert in this particular topic, but what is your experience with the proper ways to clean equipment that's so, I think the right word is multi-surfaces, or ECMO equipment has so many nooks and crannies in the hardware that it seems almost impossible to really disinfect that equipment between uses.
Yeah, no, this is something that I've had a long back and forth with the BCU leadership at our institution about. So, I think number one, would I put, my brand new $110,000 console in that room? No. They're going to get the end of life Rotaflow. They're going to get the high mileage Gen 2 Centromag console. So maybe we'll get a Gen 3 sometime. But I think we need to put our more affordable equipment in that space, because there is the very realistic possibility of it becoming so soiled that it cannot be, that we would not be able to clean it. For the respiratory viruses, I think topical surface wipe down it will be pretty reasonable and safe. I think what we would come in, any virus or pathogen that is transmissible through bodily fluids and that can live on surface, if there was contamination on the surface of the equipment there, I think we would just sacrifice that equipment and it would be gone.
Thank you, Dr. Harper, for a great talk. Couple things that we identified in West Michigan with the BCU there was who gets to go in. You know, who, and if they go in, who are we allowed to put on ECMO at that point? Because as you know, it's very restrictive, and with only having maybe 4 rooms or 6 rooms at the most, that one patient's going to occupy that whole space, and that makes it really challenging. So has there been national criteria set, or is it BCU by BCU based?
Right now, it's BCU dependent. What I have advocated for is something of kind of a national standard that we would follow, even so far as to have a panel like leader, where we would have, say, we would identify leaders from other BCUs to get on a conference call and discuss, like, are we going to offer ECMO to this patient, to make it also a little dispassionate, so that you don't have the people at the bedside who feel committed to that patient making emotional decisions, where I think we need to be as probably emotionless as possible. So I think that's what I would personally like to see happen. I think we're talking about, like, I don't think it's necessarily risen to the level of importance that the BCU leadership nationally feel like it's not a high on the agenda item, because it's such a low frequency possibility.
Hello. I'm almost inappropriately happy that you have brought special pathogens into this space. I observe that the world is changing and people are moving. I think that people moving into the peripheries of cities will bring them in close proximity, and you'll see increase in transmission of respiratory pathogens from places that normally they would have been sequestered. I think monkeypox, respiratory pathogens, I think this is coming. I'm very happy that you're pursuing this. Can you tell us anything about, in terms of ECMO and your reading so far, can you tell us anything about disseminated intravascular coagulation and its effects in support?
I think we've all seen DIC in non-special pathogen patients, whether it was just post-surgical patient who is so inflamed and now DIC, or some of seen this in influenza, other bacterial pneumonias as well. So if they were kind of de novo DIC, I don't know if I would offer it up front. It's not a good answer. I don't know. I think the impact, because we're serving a little bit of two masters here, right? We want to take care of the patient, but do we want to we also have to take care of staff. And so if you have a patient who is, truly like hemoptysis, bleeding from every orifice, is high risk to contaminate staff, contaminate equipment, contaminate the space. Is that an appropriate patient to put on? I don't think we've really answered that question yet. It's tough. I think for a novel respiratory pathogen, I think it's a lot easier for us to make decisions. Oh, yes, we should do this. Just because the disease is different or unique doesn't mean that we shouldn't try and offer typical or standard things that we would offer. When we get into viral hemorrhagic fever, things like that, it's iffy. I think the Hanta experience is encouraging that we can take those patients and get them through. So I guess it would matter the degree. There's DIC and then there's DIC. Again, not good answers to any of these things, because I don't think I think we're going to be figuring it out as we go for a long time.
Yes. So thank you, Dr. Harper. Very informative. I'm wondering, from your level as an expert in the field, we've just come through coronavirus, and we've seen, I think, the politicalization of medicine and To use your words, it's not a question of if, it's a question of when we face the next crisis. What is your estimation of our willingness and our ability to deal with the next one that comes along? I'm not frankly convinced that our population is even willing to follow the advice of experts. And we certainly were using PPE in limited quantities when we started to deal with coronavirus, and in many cases, not even appropriately. So I wonder what your thoughts are on our readiness to deal with this next crisis.
It's a big question. Yeah, that's so. I would say that my level of expertise is front line in this space. I certainly can't speak from a standpoint of public health or governmental readiness. I would echo your thoughts about kind of public trust. During I never thought I would see the level of public mistrust in medicine that we saw during the pandemic most recently. It was really personally disheartening. I don't think that much of that has changed. If anything, it's probably further exacerbated. So I think that would, more so than mobilization of resources and getting the right equipment to healthcare workers, I think that's probably the bigger challenge. One of my leaders in the cardiac surgery department, he likes to say, the first step of addressing a problem is you have to address that there's a problem. You have to acknowledge that there's a problem. And we had, I'll never forget this. I had a patient on VV ECMO with COVID who was, bronchopleural fistulas bilaterally. We had to extubate him just to stop the air leaks. He had enough oxygen delivery that if he laid completely still, he could stay awake and watch a cable news channel that disagreed with the severity of the pandemic. And so while he was on VV ECMO for COVID, he was watching things about it being a hoax. And it took 45 days on ECMO to convince him that he had COVID. So that was the level of kind of cognitive dissonance that was going on in the world. So I don't think anything, again, my personal opinions, I don't think much has changed in that realm. Certainly domestically, I don't know how globally.
Thank you, Dr. Harper.
Thanks.
Thank you so much for the talk.